Much, and I think we move on to our last but not the least talk of our course, Dr. Gaurav LUTHRA, and then we'll pause for discussion. Welcome, sir.
A very good morning. There is too much, and most of these you can see that this pupil will not require a device because we'll probably be in and out before the pupil comes down further. So another situation here, you can see a small PI there. Now here we are doing a small stretch to see if we can get a pupil which is enough. Again, these are few old videos that I pulled out to see what we can do in such situations. Again, then doing a viscomydriasis here, trying to make room for the rhexis and using a globe stabilizer. Now it's at this time sometimes the pupil comes down when the moment you do a hydrodissection, that's when suddenly the nucleus gets mobilized and your chamber depth changes and you can get into this kind of a situation. Now here I wanted to showcase that once your lens is out, pupil has obviously come down a bit and you've been able to do that. And I'm trying to do cortex extraction. Now this is a irrigating chopper, irrigating infusion cannula. So sometimes when I'm doing torics and I need to visualize, or if I'm doing a polish, so this becomes like a third hand. You can just use this as a third device. And somehow my close friend Kumar and me designed this at the same time. The only difference is that I made the Y vertical and he made the Y horizontal, and then we fought about it that who made it first, because I could show him a video of this like 1 year before he started showing it. So anyway, but this is a very useful device. You have this small Y thing at the tip, and it can just be used as a third hand to go around and move the pupil away. And also when checking your toric marks and everything, it becomes very easy, so you don't need a third device. So going on, now this situation is obviously a pseudo exfoliation, and I'm trying to do in this situation without using a device, and again using viscoat, which helps you keep the thing in place. Now I know that some people don't like to do this stretch, but I've realized that if I do a little bit of the stretch, I get enough room that I don't need to put a device, because if I put a device, it will still do a stretch anyway. And most of these times I can complete my surgery without needing a device, and I only use a dilating device when I have to. So if you follow the principles, good viscoat in the tear chamber, not only to protect the cornea, but also I like to see that while some people might want to use a heavy viscoelastic, I think that viscoat does a great job of also tamponading and keeping the pupil out of the way of the phacoprobe, and also doesn't let it flutter as much. So you can see that the other thing I'm doing here, if you look at the top right, we are using an IOP of 25 millimeters of mercury, which is very good, because in this situation, as Vishali was also showing, at a very low IOP, the fluctuations in the chamber are the least. So the iris tends to misbehave the least as well. When you have a lot of high settings and high fluidics and high flow rates and vacuum, you'll tend to get the iris into the phacoprobe repeatedly. And also there's turbulence in the chamber, and you can see that you don't really need high IOPs and high settings. I'm also using very little phacopower, and I'm mostly using the forces of separation and cracking without even embedding too much. You just need to have the mechanics right, and you can get everything out, and the pupil does not come down on you. This patient was also on Urimax, and so I was expecting this patient to have possibility of floppy iris syndrome as well. So you can go through your surgery quite easily, and with little turbulence, and you can complete almost all of it without needing any device. So going on. Now here, this is again, I pulled out an old video to show what else can be done. I rarely do this maneuver anymore. I'm of course separating the synechias, but after this, during the surgery, if I remember correctly, we stained under the pupil with the air bubble there. I do a stretch. Now I'm getting sphincteric tears. Now I don't like to do this anymore. If you really want to do something like this, if there's a very tight sphincter, you can do a small sphincterotomy. Again, a very, very old scissors, Vanas kind of a thing which I'm using. I don't think I've used a Vanas now for some time. because you have very elegant micro scissors available, but basically to give you an idea that this is how you can deal with those sphincteric, very tight rings on the sphincter, because you'll eventually not be able to do much about it. Even with a Malugins ring or with hooks, you'll end up tearing the pupil anyway. So you can then get, a space to work like this. Now, going on, I think here we have again a small pupil, and I'm using phenocaine. So this has become a very useful device. Phenocaine is basically tropicamide and phenylephrine. You can see that some patients, who are not dilating preoperatively with in the waiting room with ketorolac, phenylephrine and everything will not. So here, of course, I think this patient we had taken up for a femto. So we put phenocaine, got a pupil to dilate a bit, took him to the catalyst OT, and then managed to get enough room to create a rhexis. The good thing is that if you're using a device like a BHEX or a Malugins, your incision is much bigger. But if you're making only a 1 mm side port and putting phenocaine in, you can just have a good seal, and the incision doesn't leak when you take them for a femto-assisted surgery, and you can complete the surgery without any problems there. So I just thought these few cases. Now this is a very unique situation. I had a very high hyperope who was in the 40s and wanted a refractive lens exchange because there was nothing else that was possible. We plan to do a femto-assisted surgery, and if you notice here, we are using a 37 diopters IOL. The AC depth was small but not too bad, and both eyes were planned. And when we went in for the first eye, amongst my 4 or 5 femto cases, you can see that the pupil is nice and big and well dilated. So I never suspected that I'll run into trouble. But when I went to the OT, this was the 4th case. So by the time I reached, in the Lensex, I used to get, meiosis quite regularly. On the catalyst, we don't. Even if I'm doing 7, 8 femtos, after an hour, if I see the patient, I will not see it. In this patient, you can see the capsular thing is actually lying over the iris. It's become so small that the capsule is lifted off. I didn't realize why it is there. I tried to use phenocaine. I did everything that I could. Nothing would work. So I was working through a 2 mm pupil. I tried viscomydriasis. But frankly, I was lucky that there were no adhesions and no attachments of the capsule, and because it was a very soft cataract, I could get away. So while this surgery eventually went off well and I managed to get in, now the problem was that how to plan the second eye. So here I'm injecting the lens and checking to see that everything is good. Now when we decided to go in for the second eye, I had to do something different because I was expecting it to behave the same way. So here, of course, a thick lens going in, and we managed to get a good result. For the second patient, for the second eye, what we decided was we'll do a femto anyway. We also used preoperatively, a couple of other things. I was putting ketorolac for 2 days, and I, tried to use multiple mydriatics to see whether, we can put hometropine and cyclopentolate to see if it, stays. What we essentially did was that we kept it as the last femto patient and took him in for the first, surgery. So the pupil still came down, but you can see that, I was able to. So I've never been able to understand why this happened in this particular case. And then it was refractory to anything. So after I finish, I'm going to ask Vasavada sir to see if he's ever encountered this in a very high hyperope and why this would happen. And so here, of course, you can see that surgery is much, much more straightforward. Now, this is again a very old clip, as you can see from the video. And this is probably where I'll end the surgery today. Now, this was a very high myope and a patient who was on, Urimax. And this is the time when this was floppy iris syndrome had just been described. You can see that the pupil is very, very bad. And as I'm trying to embed, it just comes out. And I'm thinking, what should I do now? I'm preparing, and I tell my assistant that, pull out the ring or whatever, the hooks at that time, whatever was available. And I'm kind of waiting. And then I think that while he's doing that, let me go back and see what, whether I can still proceed. Just see what happens. You have a full pupil. Basically, it's because of the block syndrome where the iris kind of bulges forward, and so the fluid accumulates behind it, and all you have to do is move the iris aside or the pupil aside, and the fluid trap comes out. Sometimes it doesn't come out. If it doesn't come out in spite of whatever you do, just see what's happening again. I'm kind of trying to get those chunks out before the pupil comes down. You can see that the iris is billowing, and as I'm having these, you can see that movement. Now there's fluid trap behind it. The pupil has come down. So even while my staff was trying to bring that device out, I just did the same thing. I came out, released the pressure of the fluid which was trapped behind, and you again have a full-size pupil. And this actually has happened to me a couple of times now, and I sometimes get away without using any device. So sometimes you can move the iris aside by a chopper or something and get the fluid to come out. Sometimes it doesn't happen. Then you have to just come out, let the fluid escape from the chamber, let the chamber shallow, and then see again. I was able to bring out one chunk at a time, and the pupil would come down. It's a very blurry video, but it kind of gives you the message that this is how we can do it. So with that, I'll stop, and I hope I was able to give some small pearls. So thank you so much.
Side port, through the side port, I just tent up the iris. That itself
I know.
releases it.
We usually
So,
do that in this patient. I tried that a couple
yeah,
of times.
and you
Sometimes,
showed
yeah, but
another way
it
of
wouldn't
doing
work, and then I just had to come out, let all of it escape, and then so basically the same thing,
same.
but just work like that
Yeah,
better.
but
And I
other
did it like
thing-
5-6 times, and I could complete the
The
case.
other thing, I see that, of course, I think there are also older videos. You do like to stretch your pupil a lot.
I've stopped doing it
Then-
much now, but yeah,
these
at one time.
floppy iris cases will get
Worse.
worsened.
They get worse,
So
absolutely.
how would you,
So nowadays
how
I
would
use
you differentiate one where woman is 60 years old or a guy is 60? Is it a senile pupil or is it a floppy pupil? Right in the beginning itself, you have to plan your action.
Right.
So how do you decide?
So I typically would, when I'm starting a surgery, I would assess how big is the pupil. Will I be able to complete this? And of course, there's a proper history taken. If somebody is on, sometimes even the ladies are on, the same drug, tamsulosin kind of a drug as well.
Yeah.
So we take very meticulous history about it. And then, I would typically not even do a stretch anymore. I would
Yeah.
use Viscoat and Phenocaine to
Yeah,
see
yeah.
if I get a pupil.
Yeah.
And especially now, because you can mostly finish your surgeries in
Yeah.
2-3 minutes or 4
Yeah.
minutes, the pupil doesn't really come down as fast as, in the past I would take 20 minutes to finish
Yeah.
the surgery, and
Yeah.
so you don't have much this
Yes.
thing. But of course, if there's a situation where I'm expecting that the pupil is already to begin with 3 mm, just 3 mm or something, I will move to a device. In fact, I just skipped the 3 videos of how to use the Malugins ring, the BHEX and the iris hooks, because everybody's used them. But I've seen that my usage of devices has gone down drastically. And also it helps to put some of these patients preoperatively on atropine in addition to ketorolac drops.
Ketorolac.
Yeah, so ketorolac really works well for
Works.
2 things.
Yeah.
One is for maintaining intraoperative, mydriasis, and second also for topical phacos, the sensation of pain for patients is almost negligible if they've been on 48 hours of ketorolac 4 times a day, 3 times a day. So
Nice presentation.
Thank you, sir. Those were really a myriad of cases, and every case showing a different pearl. So I think the whole message we all got is be prepared and be open to using different strategies. Don't have a fixed way of, I only do this, I will never use a device. Use different strategies for different cases depending on what you see at that point. And like sir showed very beautifully, when you have a problem in one eye, or if somebody else has done the first eye and you see iris chafing or signs of previous iris trauma, you be ready to have that yourself, because it's not like that was a bad surgeon. Maybe the eye has that predisposition.
Especially for our flax patients, we always start Nepafenac 24 hours before the surgery. Because what we've classically seen that it is well dilated at the time of the femto, but moment patient comes inside, the pupil has come down. So then we need to use intracameral adrenaline and all. And the pre-operative examination should not happen the day before you're taking the surgery, because there's iris fatigue. The next day the pupil doesn't dilate again. So we usually have at least 2 days in between the pre-operative and the final surgery date.
also on the same lines, sometimes the patients come in the morning, they've been dilated in the morning, and you have a long list. So the staff tends to dilate all of them at the same time. And by the time your patient comes in about 4 or 5 hours later, the pupil has already had fatigue, and they'll start constricting, and you'll have a trouble. So even that makes a difference. Also here I wanted to point out that Phenocaine, while I did show that we can use that, or one of those similar things, in our setup we realized that when we were doing trials for Phenocaine, while it works beautifully well and I still use it, if you use it, in a lot of cases, you'll sometimes see increased incidence of CME. So it has to be used only when it must be used. It should not be used as a routine. And this is not published, and this is just, kind of things without any actual proof. We don't get CME much now at all. But during this time, when we had probably used it over 100 eyes, to see that if we could get away by, just using this as the primary way of dilating the pupil without putting preoperative drops and everything. So we realized that we had 2-3 instances of CME which couldn't be explained by anything. So we stopped using it like that. We now use it for only as a reserve drug when it's required.
I think that's a great point. Anything intracamerally that you use, the lesser you can, the better it is. I remember we used to put adrenaline and gentamicin in our BSS. So
No, those cases could have been some OCTs which were not done for those cases, we actually have started using phenocaine as the intracameral first step for all our patients. All of us have started using. We have not seen any CMEs, and now it's for a number of years, and our numbers are huge also. So it could be that also, because it's such a lovely drug. You know, if we actually